on Indian Podiatry Association and Gujarat chapter. In fact, we have been talking with Dr. Maya sir and Dr. Shailesh and Dr. Ravi to organize a series of webinars where we can invite a lot of delegates and even we can spread education on podiatry and wound care. So I welcome you all for this webinar. What will we do? We have four moderators to this. Myself, Dr. Ravi Kamipli from USA, Dr. Arun Maya sir, Dean of Manipal Group of Hospitals from Manipal, and Shailesh Chotala, he's the president of Gujarat chapter of Indian Podiatry Association from Gujarat. And we have four speakers, Dr. Dr. Ashutosh Shah from Surat, then hello, and then we have Dr. Hemil Patel again from Surat. He's a vascular surgeon. And then we have Dr. Dharmesh Davda. He's also a vascular surgeon working in Surat. And then we have very known figure, Dr. Jimmy Gama. He's a very senior endocrinologist working in Surat. So first I welcome you all to this webinar, and we'll cover all the four speakers together, and then we will have question answer session at the last. So we are going to have very good presentations on plastic surgery, vascular surgery, and surgical techniques on diabetic foot care, and a role of a physician or endocrinologist in controlling sugar. That is also a very important part when we have to deal in diabetic foot care. So we have Dr. Ravi Kamipli. He's the Vice President of Indian Podiatry Association. He has completed his medical study from Guntur Medical College from Andhra Pradesh, and he's a board certified infectious disease specialist and wound care specialist working in Ohio, Lima. And he is a founder member of Indian Podiatry Association. I still remember in 2008, 2009, when we started with Indian Podiatry Association. So he was the one to force us and give us all the energy and all the enthusiasm to launch this podiatry association, because that time there was nobody working or very few people working in foot care or podiatry in the country. And with Ravi's help, we were able to launch this Indian Podiatry Association in 2009. And after that, continuously, every weekly or every day, every fortnightly, he keeps on ringing me up. And we keep on discussing a lot of things, and we are at this stage. So all thanks to Dr. Ravi for all the help Indian Podiatry Association has got from you. We have another very good moderator, Dr. Shailesh Chotala. He is a lower limb biomechanics specialist, and he has done his study from New Zealand. He is at present president of the Indian Podiatry Association Gujarat chapter, and we have been discussing with him to launch this podiatry and enhance the education of podiatry and foot care in the western part of the country. And that's how that we last year we launched in November, we launched the Gujarat chapter of Indian Podiatry Association under his shoulders in Surat. And there was something around more than 400 doctors who have attended that meeting, and we were very enthusiastic for that meeting. He has his own 2 clinics at Chotala Sayona Hospital in Surat, Jeevan Jyoti Hospital, and Surat Podiatry and Diabetic Foot Care Center. And I hope within this year, with these webinars, we are coming up with a series of webinars now. One we are doing on 31st May, and then one we are doing on 5th May, and hope so that other members of the association will also do this. So all the best to Dr. Shailesh Chotala, and he's a very energetic and very enthusiastic worker. And he is working with his patient during the lockdown. Also, he was working with his patient, and always he keeps very enthusiastically takes care of the patient. So all the best to you, Shailesh. Now we have another very important moderator, Dr. and very senior professor, Dr. Arun Maya sir. He is the professor and dean of the Manipal College of Health Professions from all the group of Manipal hospitals, and he has a center for diabetic foot care and research in Mahe in University of Manipal. So he is the chief of that. He has completed Forgandry International Fellowship in the University of Alabama, Laser Fellowship from France, and Podiatry certification from UK and Finland. At present, Dr. Maya sir is the president of Indian Podiatry Association for Karnataka chapter, and we are very proud to have him over here in this webinar. And he is the membership director, World Association of Photobiomodulation Therapy and Laser Therapy. Expert Advisory Group and Biomedical Device and Technology Department program, which comes under Government of India. And we welcome you, Dr. Arun Maya sir, do this webinar, and I always keep on discussing with him. And for this webinar, and also on 31st, we'll be able to have his views and his lecture on biomechanics, he has been his main field of work. And we get a lot of education from him, and I think all the students who have been here today and in the next webinar, so he will have a lot of education from Dr. Mayas's experience. So I welcome to you all do this webinar, all the moderators. So thank you so much for joining us today. And now I'll introduce the first speaker for today, which is no less than Dr. Ashutosh Shah. He is also a very senior consultant in plastic and cosmetic surgery. He is member of Association of Plastic Surgeons of India, and he's also the member of Indian Podiatry Association of the Gujarat chapter. He's member of Indian Association of Aesthetic Plastic Surgeon, and he's a director of Apple Hospital in Surat, Elegance, the Surat Hair and Cosmetic Laser Clinic, and Matria Multi Super Specialty Hospital in Surat, and United Green Hospital in Surat. So I welcome you to this webinar as a speaker, and he will talk mainly a role of the plastic surgeon. We all know that diabetic foot care is a comprehensive and team management approach. We need a podiatrist, a diabetologist, a general surgeon, a plastic surgeon's role. A vascular surgeon is very important, which we'll be covering in the next topics, and a role of an endocrinologist. So that's why particularly in this webinar, we have covered plastic surgery, a role of orthopedic surgery, a role of vascular surgery, and always the role of a physician or a diabetologist in this. So I welcome Dr. Ashutosh to share his slides. Thank you so much. Dr. Ashutosh, hello. You can share your slide.
Good evening, sir. Yeah, I'm sharing that.
Yes, yes.
By the way, I'm recording this presentation.
Okay, okay.
Yeah. Can you all see this?
Yes, yes, it's available.
Oh, okay. So I think mine is first lecture.
Enlarge it on
yeah,
the bottom.
Yours is the first lecture, sir.
Okay, so I'll start.
Can you please enlarge the slide on the right bottom? Can you put it full screen?
Sure, I do it. Yeah, we have done it.
Thank you.
Okay, so good evening, everyone, and all attendees of this webinar. And I thank Dr. Shailesh Chotala and Dr. Suri sir to involve me in this activity. Actually, I am with IPA for I think more than now 6 years when Dr. Suri started his first meetings in Delhi. So I was only one from Gujarat who joined that meeting. And since then, I was knowing Dr. Suri, and who is doing very good work in this diabetic food. So my interest started there, and till then with his guidance and materials also from him, I have treated so many diabetic foot patients now. But now the things are changing, and my lecture may be point to be changed nowadays. What we do, I'll say about that. So I'm a plastic surgeon, and diabetic foot, as you all know, are starting with small ulcers. My lecture contains some images from Dr. Madhu Perisamy, who is a plastic surgeon in Coimbatore Ganga Hospital, and I thank them for his photo courtesy, and images from IJPS also. These are the topics which are quite recent, and I have also recently started. Before 6 months I have started this doing. So now all we know the grades of the ulcers are risk, but there is no ulcer. Like con and callosity has developed and ulcer is not there. Grade 2 is superficial ulcer without infection. So ulcer is there, but it is very superficial, not attached to or not communicated to any tendency or deeper structure. Grade 3 is crippled foot, in which the ulcer is big, or you need any type of debridement and plastic surgery coverage for that, is the grade 3 ulcer. And grade 4 ulcer is critical foot, where you may need amputation or patient death can happen in this critical foot. So our ulcers are of grade 1 to grade 4. Presently in India, what we are getting as a plastic surgeon is grade 3 and grade 4 ulcers only. And most of the time, patients also don't understand the importance of being in grade 1 and grade 2. So what is important in grade 1 and grade 2 is, when we see the patients of gangrene or cellulitis or amputation or ketoacidosis with infection, 85% of the patients are having small non-infected innocent looking ulcer before a week or before 2 weeks. So this small innocent looking ulcer can lead to the bigger complications. So now the whole focus is changed to the treating of grade 1 and grade 2 ulcer and how to prevent them to go to grade 3 and grade 4. All of us are doing great podiatric work, and all are debriding, and all we are taking care of callus, and we are all treating ulcers and treating it with the external offloading. So now what is the management and what it has changed now? So grade 1, usually we manage it with footwear and foot care. If ulcer is developed, then usually we give offloading. So till now the concept was external offloading. We make various type of footwear in which that ulcer part was offloaded. Grade 3 and grade 3 requires major plastic surgery reconstruction, and grade 4 requires amputation, or the patient may be in serious case. So what happens is, now there are so many ulcers we all have noticed, but we know that the ulcers are at very special sites only. Like if I name it, then they occur at the tip of the toes, or at the IP joint of the great toe, or at the metatarsophalangeal joint of the great toe, or metatarsophalangeal joint of the other toes. Then midfoot ulcers and hindfoot ulcers. So these are the common ulcers in the normal looking foot. If the foot is in varus or in external rotation, then the ulcer may be changed. So now what happens is, most of the ulcers, around 70 to 90% of ulcers, will fall in these sites, very special sites. And now the researchers have found out the special biomechanics for each ulcer. Like if you are getting ulcers at the IP joint of the great toe, then your foot's windlass mechanism, which is made by the plantar fascia, is deficient, and due to that deficiency you are repeatedly getting that ulcer. So now what till now we all were doing was, we were doing debridement, we were doing foot care, and then we were giving offloading in the footwear. So the problems wearing footwear is, nobody can wear footwear for 24 hours. Like in Hindi rituals, so many of us don't go in our kitchens with footwear, or in our temples with footwear. So we need to remove the footwears. And to have that footwear for 24 hours, even with the dressings, is very difficult. So the compliance of the patient to wear that special footwear is quite problematic after some time. Initially they'll wear and they'll take care, and the ulcer will heal. But once it heals, the patient will think that this is healed and now we don't need to take care of that part. But it is needed that inside there is something which is causing abnormal pressure at the same point. So once the patient start walking without offloading shoes or offloading footwear, the same point will recur. So till now what we were showing was, this was ulcer and now this is healed. But nobody was showing the delayed healing ulcer, like non-recurrent ulcer. Ulcers heal, but they should or they must remain healed for a long time, as every time the ulcer recurs, the trust of the patient goes down for the treatment, as well as the repeatedly cost will cause patient not to take treatment, or they run away from the treatment. So what happened now is we have understood biomechanics of all these common places of ulcers. Like if you have hind foot ulcer, your TA mechanism, tendo-achilles mechanism is weak. Or if you have forefoot ulcer, your tendo-achilles mechanism is tight. So it is not allowing you to walk on your heel. So now the biomechanics for all type of such common ulcers has found out, and the procedures also are designed to correct these high pressure points, and it is called surgical offloading or internal splinting. So till now what we were doing was external offloading, but this is a new concept called surgical or internal offloading, through which we transfer some tendon, or we release some tendon, or we do some osteotomies in a way that the pressure point where the mechanism was faulty, we correct that mechanism in a way that the mechanism will not allow the high pressure point to be there all alone. So usually this grade 2 or grade 1 ulcer or callosity heal by itself without any intervention, and they remain healed for a very long time with this new technology or new surgeries. If I show you some points, these are the grade 2 ulcers. This is due to the flexor hallucis longus tendon. It is due to the contracture of the FHL, and if you release FHL, this toe will not bear the pressure and it will heal by itself. Similarly, the same thing can be done with the either Calderstone-Taylor procedure or simple flexor tenotomy of the toes. By that, this toe will not touch the ground, and this ulcer will heal without any footwear, without any treatment. Similarly, if you have grade toe IP joint ulcers, it is due to the windlass mechanism which is tight. Once you allow it to heal it by external offloading or by footwear, it will heal. But once patient leave the footwear, it will again recur due to that internal mechanism. So in that, Keller's or arthroplasty is the treatment where we remove the base of the proximal phalanx and the intraosseous attachment to that. So thereby the pressure to the IP joint, which was abnormal pressure coming to the IP joint, will not come there, and the ulcer will heal by itself without doing anything, and it will remain healed for a very long time. Similarly, these are the procedures for first MTP joint, as if the smaller MTP joints are there, if the head is not osteomyelitic, we can do sliding osteotomy, or if the head is osteomyelitic, we can remove that. But first, metatarsal phalangeal joint is very important, as it bears 70% of the weight for the foot. So we don't remove the head of the first metatarsal. Instead of, what we do is we transfer the extensor hallucis tendon, which is attached here, to the metatarsal, so that now it will pull up the metatarsal, and the pressure on this area will reduce permanently, and the ulcer will not recur even if the patient is not wearing the footwear. So these are the commonly ulcer in the foot. Now forefoot ulcers, if they are there, then the tendo-achilles is short, and for that we can do tendo-achilles lengthening or gastrosoleus recession. There are various procedures depending on the ulcer. For hindfoot ulcer, the tendo-achilles mechanism is weak, so we can strengthen it, we can re-repair it, or we can reconstruct it. Charcot foot, you all know, it's a midfoot collapse, and if you find it out early, then bony fixation if done earlier, then the Charcot foot can also be healed, and inversion or eversion of foot can be also corrected with the tendon transfers. So advantage of surgical offloading, I repeatedly told you, is it's a simply understanding and changing the biomechanics that will prevent the recurrence of ulcer. It gives internal splinting. So prolonged use of offloading footwear is not must. And once ulcer is healed, the patient remains motivated to take care of their foot, and healed ulcer, there is no risk of progressive infection. We can find out this and we can monitor this with the pedobarogram. As you all know, pedobarogram, like this, the high point ulcer with the internal splinting, you can show that patient previously the pressure was coming here and now the pressure is not coming. So even if you can objectively show them this is a ulcer and pedobarogram what we have done. Now after this I am talking only 2-3 slides for grade 3 ulcers. If the grade 3 ulcers are there, then we can debride it. We can see the vascularity. If the vascularity is not good, we can refer it to vascular surgeon, and thereafter we can debride it. NPWT, negative pressure wound therapy, is the new thing in this. We can apply negative pressure wound therapy over this, and the infected ulcer can become granulated, and over that we can do grafting or primary suturing. If you have very big ulcer, then also they can heal, and after that they can be on podiatrist care for a better prosthetics or the offloading footwear. Similarly, this type of bigger ulcers also can be debrided, and they can be covered to with the flaps, either the pedicle flaps or free flaps. Even the free flaps are possible in diabetic patients also if they have good vessels, and the patient can walk on their own feet. Similarly, very big cellulitis also can be corrected with the help of NPWT, primary coverage, and skin grafting. So our full changing is what we have understood by the biomechanics, that if you change the normal biomechanics was changed due to diabetic and diabetic neuropathy and diabetic motor changes. So if we can revert it, or if we can change it in a way that it will not cause pressure to a particular point, that the ulcer will heal by itself and they will remain healed. This is the new concept in diabetes, and there are various procedures. So many procedures are there. I have shown only 4 or 5. There are so many procedures depending on the pedobarogram. We cannot do we cannot do all procedure to all patients, but we need to tailor made depending on the inversion, eversion, or pedobarogram reading. And that the way we can change the things, and we can keep ulcer healed for a long without much intervention. Thank you for your hearing.
Thank you, Dr. Shah, and I think it's a very good presentation, and we have got a very good take-home messages on tendo-Achilles lengthening, role of tendo-Achilles lengthening. It's a very good and daycare procedure. We all practice a lot in our practice also, and this is one of the things where patient can go back home the same day. And I think more than 90% of the forefoot ulcers, any ulcer under the toe or in the forefoot region, is gets healed within 2 to 3 weeks of time if you do percutaneous tendo-Achilles lengthening. Then, as I said, tendo-Achilles strengthening, as emphasized by Dr. Shah, this is also very good technique. And inversion and eversion of the foot can be corrected by tendon transfer. This is also very good technique where you can just offload the pressure. It is called surgical offloading. And now I think the take-home message of today's webinar should be this, that how we can do surgical technique. And I think Dr. Shah has very enthusiastically and very clearly made these points that how we can do this, because what we see in our practice is that these patients come back to us after the healing, because after 2 months, after 3 months, if they are not following the proper offloading shoes or sandals or footwear, they come back to us with a re-ulceration on the same day. So if you have this technique, you can discuss with your vascular surgeons, anyone who's dealing into diabetic foot care, and you can get these surgical offloading techniques done in your patients. And then I think the long-term results will be very good. So thank you so much, Dr. Shah. And now I invite Dr. Ravi Kamiple from USA, and it's a good morning for him. It's a early morning, and we told him that we'll be starting this at 5 o'clock. So Shailesh told me, I'll make Dr. Ravi to get up early in the morning. So I invite Dr. Ravi. So,
Thank you.
I join you, and he is very enthusiastic now on obesity and keto diet. We have a separate group running where Dr. Ravi is the Shah Rukh Khan of that group, and, it's a very good education he is doing in keto diet and obesity and metabolic syndrome. So we'll have few words from him, and then he will invite Dr. Hemil Patel, who's a very enthusiastic and very efficient vascular surgeon in that part of the country, in Gujarat and Surat, and I know he has very good results in his practice, and Dr. Shailesh keep on talking about him. So Dr. Ravi here.
So basically, this whole, thank you for the series of things that we are going to start doing, and particularly, hopefully, in the next month, we'll pack in a few knowledge bombs. And what we are trying to do with IPA is to spread the knowledge of education across India. And also, as we do that, we hope to bring in different solutions, including telemedicine solutions to the group. And we will empower the group to deliver their services. And part of that knowledge spread is also understanding the main processes that are involved in care delivery, which would be podiatry, wound healing techniques, and also infection, offloading techniques that we have different specialists, and surgical techniques. And also the idea of nutrition has boggled me since 2005. We do a lot of things in medicine, and the major thing we don't do really is nutrition. I don't want to take too much time today because today's presentation is not focused on nutrition, but I just want to share like 3 or 4 slides just quickly to, let me start the sharing. I just will share it quickly so that with 2 or 3, and I'll just go to this one. I want to bring to the notice of the group the idea that we do a lot of insulin testing, a lot of glucose testing, but nowadays the idea of continuous glucose monitoring is going too much. And the idea of delivery of any service line has to depend upon how we democratize the service line. So we do great care in whatever we do, foot care, podiatry care, the surgical care, or whatever we do, diabetes care. What we forget is we don't really focus on giving the autonomy to the patient, autonomy and mastery of their own problem to the patient. And we have to be the people who have to democratize that care delivery process. And CGM, okay, continuous glucose monitoring, is a huge thing. And if you see here, somebody who has hemoglobin A1C of 7, I mean, their glucose can go vary like that, but target in range seem to be an amazing thing. We'll talk a lot about this later, but what I want to show you is this the green range, where most of it has to be between 70 to 180. That's what impressed me. I just wanted to quickly share with that. And also, we have to understand that it is not just the glucose. It has a lot to do with insulin. So as a part of this whole journey, I'm working on a project to bring testing of insulin at the bedside to whole of our IPA and the wound care group that are working with us. So I would encourage us to please join the nutrition group too. So one last slide is how in this COVID era, how are we going to survive and thrive is to stay away from processed food, eat real food. And thing is, we have to do what do we eat, when do we eat, and how much do we eat is the whole thing, like we need to cut carbs, prioritize protein, fill with good fat. Saturated fat, by the way, is not bad. And we have to figure out intermittent fasting, and satiation, sleep well, reduce stress, and have good sunlight, hydration, and exercise, and some vitamins. So that's it. I'm just going to stop the screen share here because we have other people to speak on. Let me go and do that. And so with that, I will try to introduce our next speaker, who is Hemal Patel is the next speaker, with him having done significant discussions on different aspects. And I had the pleasure of being a part of IPA opening last year when we had, I was in India for a long time. And I was at Surat, and Hemal had an amazing presentation. And he is a vascular surgeon and is in Surat and has been awarded the President's Gold Medal in the field of peripheral vascular and endovascular surgery at India level. So thank you, Hemal, for joining today. And please take it away.
Yeah, thank you, sir. Thanks for your nice introduction. Am I audible?
Yeah.
Yeah. Good evening, everyone. Hope everyone doing good at in Corona times. I would like to share my screen now.
Double click. मैं करूँगा ना.
Yeah. When the meeting was there in Surat, we came with a slogan: Indian Podiatry Association can also be an I prevent amputation. We'll be talking on the DYSVASCULAR foot. That is an interactive session. We'll be going ahead. What is the definition of a DYSVASCULAR foot? There is no clear definition as such, but a decreased vascularity of the legs with ABI of less than 0.9 or a TBI, that is a toe brachial index, of less than 0.6 with or without symptoms, or an ankle brachial index more than 1.3 indicating heavily calcified and non-compressible arteries can also be included under DYSVASCULAR diabetic foot. Diabetic foot without palpable pedal pulses, that is a second definition. Everyone knows this one, so we'll not be going in detail about the etiology and everything of a diabetic foot. Coming to only the vascular part, how the PAD and everything is important. It is a relatively common condition affecting about 20% of the population older than 65 years of age. And it is associated with higher cardiovascular morbidity and mortality. What is the burden of projected data? Among around 65 million diabetics, of whom 65,000 will develop critical limb ischemia, but only 5,000 procedures are done in India at present. And amputation every 30 seconds due to diabetes. Despite of all of us trying to prevent that, still this holds that every 30 seconds a person is losing a limb. Typically, patients with critical limb ischemia have multi-level disease, starting from aorta, iliac, femoral, tibials, and everything. But what is more important is, in diabetics and patients with an end-stage renal failure, about 60% of the patients will have a multi-level and below tibial, that is below popliteal, that is isolated tibial disease. That is very tough to treat and to salvage the foot. But how we do it, we'll be just showing you in next slides. One most important slide, what I think is the 5-year outcomes of peripheral arterial disease. If we see the patient in our routine OPDs, and every one of us just examine a pulse, and if he's a stable claudicant, if we advise him foot care or footwear, he will be a stable claudicant for another 5 years. Only 5 to 10% of them then shift to the critical limb ischemia. So it's a big thing. We can prevent the patient from shifting from stable claudication to critical limb ischemia by just teaching him the good healthy lifestyles and foot care and footwear. Important slide. What we all know is many things outside the who doesn't know about this all. They always say, oh, only an amputation, let us do an amputation rather than going for the limb salvage and everything, which will take a longer time of 3 months, 4 months, round the round. But it comes down to the third largest cause of death at a relatively a 5-year mortality rate, holding up to 68%. The magnitude of problem and impact of preventive measures. We'll not go into this. 85% of diabetic foot amputations are due to inadequately treated foot ulcer, of which 7 to 20% with foot ulcers eventually needs an amputation. Majority of injuries occurs at home, which Dr. Ashutosh Shah told that we need to prevent the foot care even at home, starts from home. Caused by barefoot walking and poor footwear, lower incidence of recurrent ulcers if footwear is worn inside and outside the house. Simple measures to prevent ulcers could reduce the amputation rates by 50 to 60%. Amputation in diabetics, 50 to 75%. See the important operative mortality of just doing below knee or above knee amputation holds around 10 to 15%. When it is compared to cardiac surgery mortality, it is hardly 1 to 2%, or a vascular surgery mortality, which is hardly 3 to 6%. 30 to 50% amputees will require a contralateral amputation within 3 years. 40% mortality in 3 years in amputees because of increased cardiac workload during ambulation. It's an integrated practice where all the specialties needs to come together and treat the diabetic foot and prevent amputation. What holds good is just an education. If the patient is educated, you can bring down the major amputation rate right from 60% to 5%. Below knee from 35% to 15%. And minor amputations from 46% to 12% on a view of just an education. These all figures are not to afraid all of us, but this is what the reality is. Now, increasing in the science knowledge and the technology, being a plastic surgeon, a vascular surgeon, a podiatric surgeon, we all can come together and bring down this all rates. We'll be just talking about vascular procedures and how we can increase the circulation and prevent the further amputations. A vascular surgical branch is a surgeon who provides both endovascular as well as an open surgery. And they both are complementary to each other. And the approach is definitely from patient to patient. Not that each and every patient will require only an endovascular, not that each and every one will require a surgical. We can even provide a hybrid approach in many of the patients. Aortoiliac, relatively spared in diabetics. Most of the disease involves infrainguinal arteries. 60% involves the digital arteries and the plantar arteries. 80% have microangiopathy. Why we should offer revascularization? As already told, 30% has a chance of contralateral amputation. Indians have a diabetics which are decades younger. Many are the single breadwinners of the family. Rehabilitation inadequate for the amputees. Older patient needs 30% or more cardiac workload to ambulate with prosthesis. Amputation are more expensive than vascular procedures in mid and long term. Morbidity and mortality is always higher with an amputation. What is the importance of clinical examination in each and every one of us? Examination of a pulse. A simple examination of dorsalis pedis, posterior tibial or an anterior artery, giving just 2 minutes of your time in daily examination, can give us an idea regarding the vascular insufficiency. Other thing, most important thing is examination. The majority we see a foot only. Hello? Yeah. Majority of us just examine the foot. We need to examine in between the toes. That is the most important thing. Sometimes there is a hidden ulcer in between the toes, which might be a bigger source of an abscess of the foot. Investigations for the vascular insufficiency can be non-invasive, invasive. Non-invasive basically involves ankle brachial index, segmental pressure, plethysmography, transcutaneous oxygen measurement, arterial Doppler. Angiogram, CT, MR angiograms, and that is a peripheral angiogram. A graph on your left shows that is a plethysmography or a sorry. It shows the pressure difference of the 154 and 157, that is the brachial artery pressures. Below, they are the pressures at the levels of the thigh, at the popliteal level, and in the tibials. If you see on your left, it basically shows the flattening of the curve, which gives us an idea that is the blockage is starting from the femoral artery. The other thing what you can get done is a arterial Doppler. This is a good triphasic waveforms which shows there is no any blockages or stenosis, significant flow decreasing in the proximal to this. Coming to a CT angio, which is done most commonly. If you see a CT angio, you will see a lot of calcifications, and many times the lesions cannot be seen which are present just below this calcium. You can see this is a male of around 60 years old. He has a occlusion, no femoral pulse palpable on the bilateral side. If you see a CT, you see that there might be no lesions above the femoral artery, that is iliacs are fine. But if you see it properly, it's a high grade of calcium which is there, and there is a severe blockage, 100% occlusion in external iliac on the left side. Same thing happens in tibial. What is seen is purely a white line. That is not a dye which is flowing, but it's a calcium which has made the artery severely highly calcified, a rock-like an artery. This is a posterior tibial artery. To work on this artery and open up is to do a good job. So better is to get an MR angio, which is but not available in many of the places, not even in Surat in the good center, where the degree of the calcium loads will be less. So you will be able to see the intra-arterial flow of the dye and the intra-arterial flow. Is there any flow limiting lesions or not? The best thing is to do a peripheral angiogram. This is a peripheral angiogram. It is same like what is done in the cardiac angiogram. We take a femoral access, give a shot of a dye. We do a digital subtraction angiogram in which the bones and the heart densities have been subtracted. So you see a black shadow, which is a dye. This is a superficial femoral artery. There is a high grade occlusion in the lower part, that is near the adductor canal, combined with a stenosis. Good popliteal artery, below anterior tibial artery not seen, replaced with multiple collaterals, tibioperoneal trunk, multiple occlusions, only a peroneal run through, no anterior tibial and no posterior tibial, and peroneal feeding dorsalis pedis artery. Diabetic revascularization, to do or not to do? Yes, need to revascularize if functional limb salvage should be obtained. Not if we don't, a large number of amputees with possibility of contralateral amputation, economic burden, increased morbidity and mortality. Not each and every case requires surgical intervention. When the lifestyle modification and medical treatment fails, a surgical intervention is required. It is required in a rest pain, non-healing ulcers, and a gangrene. Aims of surgery: restore the blood flow, reduce the complication, healing, and prevent the limb loss, which is the most important thing. There are multiple surgical options which are available. First of all, which everyone might be knowing, is thrombectomy, embolectomy, endarterectomy, bypass, angioplasty, stenting. Hybrid means we combine both surgery as well as endovascular. DEB and DES is similar to cardiac. Now drug-eluting balloons and drug-eluting stents are even available for peripheral vessels. We'll be just showing a small, the surgical types. This is a thrombus. This is a femoral artery. We have opened up arteriotomy. There is a thrombus. A large thrombus can be withdrawn from this. And we have salvaged the limb. This is an endarterectomy of a common femoral artery. There is a high grade plaque which is there in a common femoral artery, which is causing around 90% stenosis. Arteriotomy is made. We have removed the plaque. You can see a large plaque, common femoral artery, superficial femoral artery, extending into profunda femoris. And then we have done a closure with a GSV, that is a great stiffness vein patch. So a good circulation has been started. Bypass. It's a bypass which can be even from aorta to below, aorta to femoral, femoral to popliteal bypass, femoral to distal bypass, even to the tibials. If you are doing a bypass to the tibials, we mainly use a vein. This is a vein graft, that is a great stiffness vein. We harvest the great stiffness vein of a leg right from the ankle joint up to the groin, depending upon the length of the graft which is required. We reverse it and do an anastomosis to the proximal and distal side so that the circulation can be re-established. Hybrid is a very important procedure to be done as such. A patient is having an aortoiliac occlusion as well as femoral occlusion. So if you provide him only a surgical option, what happens? He will require a aortobifemoral bypass, doing a laparotomy, exposing the aorta, 4 days of an ICU stay, increase in the morbidity, lot of morbidity. So what we do is we provide him as a vascular surgeon, we can provide him both the options. So we provide him an endovascular as well as an open approach. Endovascular, aortoiliac occlusion, we have just done an angioplasty and stenting. Decrease in the flow in the iliacs and the block, we have done a stenting. So we have established a flow right from the aorta up to the femoral. And then from the femoral to popliteal, we have done a bypass. So there is no opening of the abdomen, decrease in the morbidity, patient gets discharged in 2 or 3 days. A purely endovascular is mainly for the diabetics, mainly for the tibial vessels, mainly with a multi-level disease. This is a case just done around 2 days back. There is having a femoral block and a multiple stenosis. We did only just a balloon angioplasty, no need of a stent, nicely open up the blocks. This is tibioperoneal trunk and peroneal, did just a balloon angioplasty, able to open up the complete vessel. Now the patient has a very good flow right up to the foot, that is a dorsalis peroneal feeding up the dorsalis pedis and as well as the common plantar artery. You can see the collateral circulation. This is before plastic. There was no collateral circulation. After opening up both the blocks, see the amount of the collaterals which have been developed and the amount of the blood flow going into the heel and into the foot. So if the patient comes, we have to examine the pulse. Without a proper blood circulation, whatever method we do, it's very hard to heal any wound. And now with the recent advances, even in these highly calcified vessels, we'll be able to provide a blood flow directly to the foot. Now comes to the surgeon's role in doing a debridement. Always a diabetic foot acts as an iceberg, only a small part which is visible. Just will be showing some pics. A patient with a plantar abscess involving the third toe, once done a debridement, you can see it's going to with the tibialis posterior tendon up to the medial malleolus. A central plantar space abscess, that is a preoperative. Post-op, if you see 2 toes have been cut and amputated, and this is an ideal iceberg phenomenon example. Management of foot ulcers, everyone will be knowing multiple dressings which are available, moist, hydrocolloid, alginate. But what I will tell you is avoid iodine. Hydrogen peroxide can be used sometimes even when bleeding. Usol and iodine should be avoided. You can provide a negative pressure wound therapy, and most important thing is to provide a offload. You can apply anything except patient's weight. These are the examples of the offload. Shailesh does very good work for us in Surat. This is a wet dressing. These are the examples of the patients where the vascularity has been improved. This is the pre-op image. After 4 cycles of WAC and the vascular improvement, you can see the ulcer has come to an healing and is ready for skin grafting. Bad case with a femur, with a toes gangrene, ischemic ulcer on the dorsum as well as on the plantar aspect. Did a transmetatarsal amputation, improved of this vascularity, did an angioplasty, ready with the skin grafting. I think Dr. Ashutosh Shah has done this skin grafting. Heel ulcer, similarly, it has slough, debrided, vascular repair, ready for the skin grafting. And it's done post STSG, she is fine. Just 2 case discussions. A 62 years male with all the comorbids, right grade to infected gangrene, popliteal was palpable, distal no pulses. Underwent a raised amputation. This is the PAG image. A popliteal artery dividing into tibioperoneal trunk and anterior tibial artery. Anterior tibial artery having a stenosis in upper part and occlusion in the distal part. No posterior tibial, no peroneal vessels. We did an angioplasty, opened up the whole anterior tibial artery completely, feeding up the dorsalis pedis artery. Ulcer very good shape. Post skin grafting, patient is able to walk. Second female which I've just seen, this is her images when we have done an angioplasty. Multiple stenotic lesions in anterior tibial. Did an angioplasty and see the improvement in the blood flow. This is a pre-op, this is a post-op image. The multiple blocks have been opened up very nicely. She has now a complete good blood flow into the foot. Whole anterior tibial and dorsalis pedis artery has been opened up and we are able to salvage her foot. A case with a femoral artery occlusion, just an image to show you a video small. You can see a multiple stenosis and an occlusion in this part. We have put up first did a balloon angioplasty. he had some small dissections in there, so ended up putting up a stent in which this is a stenting in the femoral artery. You can see a good flow established going into the tibials down up to the foot. This is the stent in the superficial femoral artery. Nowadays, in multiple patients, our diabetic patients will be having a high creatinine. So we cannot give them a diet. We have an option of a CO2. A CO2 provides us like a lifeline. We can do an angioplasty in all the patients who have borderline kidney functions, so that even after an iodinated CO2, the kidney functions cannot be hampered. If we use an iodine contrast on such patients, they will definitely go into the dialysis or an end-stage renal disease. So we provide an option of a CO2 angioplasty to the patients whose creatinine is borderline or his GFR is below. So this is my conclusion, that vascular repair needs to be there, and our aim should be save limbs, save lives. These are the recommendations from IWGDEF PAD guidelines. Always consider revascularization in a patient with diabetic foot ulcer and peripheral arterial disease, irrespective of the results of bedside test, when the ulcer is not healing within 4 to 6 weeks of time. Now, where do we belong? We need to see superior doctors prevent disease, mediocre doctors treat the disease, inferior doctors treat the full-blown disease, where we belong right now. And I marvel that society would pay a surgeon a large sum of money to remove a person's leg, but nothing to save it. This is just under joke period of time. Do not allow your patient to leave the clinic wearing the same pair of shoes that have caused an ulcer. This is the most important thing which we all need to consider. Thank you. Thanks a lot. Over to you, sir.
You can stop your screen, Dr. Hemel.
Yeah, just.
Thank you, Dr. Hemel, for a good presentation there. Just wanted to say, like you said, prevention is an amazing thing that we have to do, and trying to get to the prevention is where we have to figure out what we're doing, because without that, it is bad. And you're showing all those pictures that were gory and great, but the issue really comes down to how we prevent the atherosclerosis and endovascular aspect of the injury that happens. And that's where atherogenic dyslipidemia, dysfunction of the things happen. So without next ado, I would like to take Dr. Chautala. Please introduce Dr. Vagdama, and can you please introduce Dr. Vagdama further, please?
Yes, sir.
Amar,
we can invite Dr.
Yeah, go ahead and
Yes,
introduce Dr. Vagdama, please.
Dr. Arun Maya, sir.
Yes.
Oh, Dr.
Dr.
Maya.
Arun
Okay.
Maya,
Okay.
Dr.
Yes,
Arun
sir.
Maya, sir. We invite you here on the dais, and then you can give your experience, and you can invite Dr. Jamil.
Yes. Very good evening to all of you. And as we discussed today, I'll be mainly providing the overview of our center activity and also what all the important research we are conducting at Manipal. As Manipal MAHE, or the Manipal Academy of Higher Education, the reputed university in the country, focusing mainly on the quality educations and the research. And we have been attached with the 2,150 bedded tertiary care hospital.
So,
where we have
Shailesh, you need to stop your screen first so that Dr. Maya can share his thing.
Yes, sir. Please continue, sir. Maya, sir.
Maya, if you have any screen sharing, please go ahead and.
Yeah, just only one.
Dr. Shailesh, put Dr. Maya's screen.
Yes,
Dr.
sir.
Maya's slide.
Yes, sir.
Dr. May, do you have the screen share? Go ahead and do it, please. Just go ahead
I'm
and start.
doing, sir. I'm doing.
Yeah, okay. Yeah.
Yes,
Here we
that's
go,
okay.
sir.
Yeah.
You can speak, sir, now.
Yeah, good evening to all of you. And today, as we discussed, I will not going to do any presentation. However, we will be highlighting on our center activity. As I mentioned, the Manipal Academy of Higher Education, or the MAHE deemed university, is one of the top ranking university in the country with a global reputation. And also we have been attached with the 2,150 bedded tertiary care hospital. And we have a comprehensive center for diabetic foot care and research. And in our center, we have a team of experts, and our objective is more of a prevention rather than focusing on any curative approach. Our focus is mainly on the prevention, early screening, identifying the diabetic foot syndrome, and then go for an appropriate therapeutic intervention. And also parallelly, we also have a center where in case if the patient requires any surgical or the advanced care, they also will be treated with those advanced support also. I would like to highlight here, as part of the World Diabetes Foundation research, in our district we have screened more than 1 lakh populations, and based on our research we found about 14% of the people are with the diabetes, and among the diabetes, even with the more than 2 years of type 2 diabetes mellitus, the people are having the neuropathy or the diabetic foot syndrome ranging from 24 to 49%. And in our center, we have a comprehensive screening for the detailed neuropathic assessment, the vascular assessment, and also we focus mainly on the musculoskeletal and the biomechanical assessment. And as in the two speakers, I've already highlighted the importance of the diabetic, the assessment of the biomechanics of diabetic foot. In our center, we have a comprehensive assessment for the biomechanics of the diabetic foot. We identify the plantar pressure changes even in the early neuropathic patients, or even in the patients with the moderate or the severe. Based on our data, what we observed is, the most importantly, even in the early neuropathic patients, we can observe, especially in the base of the second and the fifth metatarsal head, we found a drastic changes in the maximum plantar pressure. So if you correct that with a conservative approach, like an appropriate insole or an appropriate corrective footwear, you can prevent a lot of subsequent complications like preventions of the callus or the ulcer. And we have a database of more than 10,000 people. We have been following them from the last 4 years. And we have observed that even with the high risk neuropathic patient, if you go for an early screening for the biomechanics of the foot and then provide a corrective measure, you will be able to prevent a lot of complications related to the ulcer or the Charcot foot also. And as part of the center also, we have there are 7 PhD scholars. They are doing their work in the area of the diabetic foot, mainly focusing on the vascular related issues, and we are establishing the database for toe brachial index as well as the ankle brachial index. Then also we focusing on the biomechanics aspect. We have been getting a copyright, and also as we mentioned shortly, we will be releasing one book on the clinical biomechanics of diabetic foot. I just wanted to give an overview about the center, and now I'm very pleased to introduce our next speaker, Dr. Jimit Vadgama. Dr. Jimit is a fellowship in endocrinology, diabetes, metabolism from Mumbai, as well as the MD in medicine, and also a certified diabetologist. And he's a consultant endocrine, diabetes, and metabolic physicians in Surat. He is an author in the Research Society of Studies in Diabetes in India, the textbook of diabetes, 4th edition, and TIASA National Award winner in 2016. He is a member of the American Association of Clinical Endocrinologists, USA, former assistant professor of the medicine, GMC Surat, and is having rich publications in the field of the diabetic foot. I'm very pleased to introduce our Dr. Jimmy. He will be speaking on the management of the diabetic neuropathy. Over to you, Dr. Jimmy.
Thank you, Dr. Arun sir, for the kind introduction. I'll be going through the
Please,
management
please
of
mute, please
diabetes.
clear all delegates to please mute yourself. All delegates. Yes, yes, Dr. Jamit.
Yeah. So thank you for the kind introduction. So today's topic, and everyone, all other attendees are waiting for the food management and all those things. This is a little bit out of track topic, but we will like to cover a few things that are very important. Though the time is very short, I think only 20 minutes are left for the allocated time. I would like to finish it as soon as possible. So what I'll be speaking on management of diabetic neuropathy. Okay, I think the slides are visible to everyone.
Yes, yes.
Yeah. Okay, thank you. So what will be going a little bit introduction, few important differential diagnoses that are important clinically. Now we won't go for all those rare conditions, few of the investigations, how we can manage it clinically. And we won't be discussing about autonomic neuropathy here specifically because this is a podiatry webinar, and we won't be discussing about cranial nerve pulses that are associated with type 2 diabetes in general. Okay, so we all know that the presence of symptomatic and or signs of peripheral nerve dysfunctions in people with diabetes after other causes have been excluded, you can label them as diabetic neuropathy. So important thing is you have to exclude other causes. So it is very common complications affecting more than half of the patients with diabetes. Many of the time it is frequently asymptomatic also. It is mostly untreatable. There is no cure, unfortunately. It requires careful examination and assessment to detect it. It affects quality of life. Very, very important. Pain and depression are the thing. We are not considering the ultimate outcome after the amputation, the quality of life after amputation. But it definitely affects pain and depression. Okay. Patients with diabetic neuropathy are 15 times more likely to have lower limb amputation. Very, very important thing. And food problems are the common reason for inpatient admissions. Okay, for the diabetic patients. And death is most frequently due to the cardiovascular disease. I think Dr. Hamil has already discussed it. Okay, so what causes diabetic neuropathies? We know about metabolic factors, high blood sugar level, long duration of diabetes, abnormal blood fat levels also. Another thing what I would like to know about insulin resistance and inflammation. Okay, there can be a possible cause for the diabetic neuropathies also. In neurovascular factors leading to damage to the blood vessels that carry oxygen and nutrients to the nerves. Many autoimmune factors, they also come into play. Mechanical injury, actual injury to the nerve, additional lifestyle factors such as smoking and alcohol, they can also affect. So what is the clinical impact of diabetic neuropathy? Why we are discussing it? We know it causes painful symptoms. It causes impairment, disability, and sometimes handicap also. So ultimately it leads to reduced quality of life. Neuropathy deficits are also there that leads to ataxia, weakness, foot ulcers, Charcot foot. Ataxia and weakness can lead to falls and fractures also. And ultimately leads to increase in the mortality, morbidity, and even cost for a diabetic patients. So important thing, as I discussed earlier, whenever you want to label it, your patient with diabetic neuropathy, first and foremost is a common sense. And second thing is the ruling out other causes of peripheral neuropathy. So ruling out of peripheral neuropathy, what are the other causes apart from diabetes? Even Guillain-Barré syndrome can cause peripheral neuropathy. But remember, it is one of the acute and dramatic presentation is there. B12 deficiency, very, very common in India and very, very common in type 2 diabetes patients also. Alcoholic neuropathy, again, very common. Some heavy metals and other toxins can also do and damage your peripheral neurons. Chemotherapy, vasculitis and connective tissue disorder, HIV and sometimes ART also, amyloidosis, porphyria. In India, specific another cause, leprosy can also cause neuropathy. Okay. So before going to diabetic neuropathy, I would like to highlight two of the things. One is B12 deficiency, very, very common. In Western countries, up to 20%. In India, it will be very high due to vegetarians and medications of metformin. So malabsorption, insufficient intake, specifically in vegetarians, patients with pernicious anemia, gastric bypass surgery, and patients on chronic metformin therapy are the very well established causes of B12 deficiency. Usually it causes distal sensory and motor loss, similar to what is kind of a diabetic neuropathy. Very rarely, when this deficiency is very severe and long term, it can cause combined subacute combined degeneration of the spinal cord also, and that can be a serious disease also. Supplementation we usually give a oral route, but sometimes it is required intramuscular route also. And in India, we have now intranasal spray is also approved for B12. Okay, alcoholic neuropathy, chronic alcohol consumption can cause painful diabetic peripheral neuropathy, but there is no reliable successful therapy. Nutritional deficiency, specifically we know about thiamine deficiency that occurs in chronic alcoholics, and or it is the direct toxic effect of alcohol or the both factors. They have been implicated in the alcohol-induced neuropathic pain. This can be achieved by alcohol. The recovery can be done by alcohol abstinence and nutritionally balanced diet supplemented by all vitamin B. So as I said earlier, diagnostic approach, first thing and foremost is the common sense. Okay, if your patient is having long-standing diabetes, there is uncontrolled blood sugar level, they have a distal involvement, symmetrical involvements, lower lymphs. We all know about the simple basic thing. If it is there, most of the time, your patient will have a diabetic neuropathy. Okay. Diagnostic approach, sometimes it is needed for a complicated cases. As I said, whenever the patient has atypical presentation, like proximal involvement is more, upper limb involvement is more, it is not symmetrical sometimes, then you may need to differential diagnose it, and sometimes you will need specific studies here like nerve conduction velocity studies and electromyography also. So this is a big approach. Usually we leave it to the neurophysicians here in our clinical practice, because the other causes which are usually rare and they are generally associated causes with type 2 diabetes. So for our part, type 2 diabetes management remains mainstay, but sometimes very rarely we find these atypical neuropathies, we refer them to neurophysicians, and this whole differential diagnosis beyond scope of today's presentation. But what is important thing is you need to examine your patient's feet. Okay, so all the guidelines they recommend that even ADA and all the other guidelines that for each visit of your patient to your clinic, you must examine your patient's foot. Okay, you should see for autonomic features also. So dry skin, hairless, distended veins, edema, or charcot is there. You should examine your feet, all those things. I think this is covered many a times in all the webinars, and even few of them are covered in today's lectures also. One thing you need to remember is no diabetic enters your cabin with their shoes and socks on. So you must examine your patient's feet. Okay, examination wise, clinic bedside sensory tests are must. I do examination or the even 10-gram monofilament test and tuning fork test to all my patients that are coming to my OPD. This is must. Okay, even in busy OPD, I never miss it, and it is a routine protocol that the patient needs to go through these tests. Okay. Kind of footwear is also very, very important, because inappropriate footwear is the commonest form of trauma. And I would like to say in India, it is very, very common thing. And sometimes we see a horrible scenarios, even all those metals are there in the footwears also. This is very, very important thing. Do not forget to look into the shoes. Bare minimal investigation for DPU. These are my recommendation. Just apart from the comprehensive metabolic profile, according to the patient's profile, you do fasting PP, HbA1c, and related metabolic investigation. Apart from that, CBC, B12, and I usually give them a thyroid function test also, because type 2 diabetes is usually we see patients, they are visiting the tertiary care clinics. The thyroid dysfunction is also very, very important thing. And we know hypothyroidism, there are numerous articles and publications that say hypothyroid and hyperthyroid both can affect your peripheral or the neuropathies. So even we know hypothyroid, carpal tunnel syndrome is very, very common. In hyperthyroid also, there is hyperthyroid neuropathy well established. Though there are no patients, I add thyroid function test also. Management of neuropathy, as I said, the very first important thing is important of diagnosis. Common sense first, and you do the differential diagnosis of ruling out the other causes. You need to recognize the underlying cause also. Glucose control remains the mainstay. Okay. Apart from that, vitamin supplementation, stopping of alcohol and smoking, managing and preventing complications is also very important. So ultimately the mainstay of treatment or single line management, if you say for diabetic neuropathy, it is just symptomatic treatment and prevention of complications remains the mainstay of management. So it is unfortunate that despite the discovery of so many things in diabetes and metabolic disorders, even in other complications like cardiovascular disease or peripheral artery disease or other retinopathy treatment, all other nephropathy treatments, the peripheral neuropathy treatment in type 2 diabetes remains unneglected, or remains they are out of focus of all the pharmaceutical giants or research institutes, that no major breakthrough treatments are coming from years. Okay. Only what remains is the symptomatic treatment and prevention of complications and the treatment of the mainstay, which in our case is glucose control. So it is unfortunate that we not have any dramatic or breakthrough treatments. Newer treatments are coming up for neuropathy. Okay. Another thing I would like to also add, that current management, and you see the level of evidence or the quality of evidence is not so good, or we don't have any major big trials for that. Okay. So symptomatic management, pain management is limited by side effects. You need to remember this also. Though we have symptomatic treatment, analgesics, anti-inflammatory, anti-epileptic, antidepressants, and narcotics, all these treatments are full with side effects. Okay? But thing is, there are so many classes of drug. What is my personal advice is you should master 2 or 3 drugs by frequent use. Use them how your patients are behaving, and you gradually up titrate them to reduce the side effects. So this is the mainstay of my personal advice to all of you. 2 or 3 drugs you start. We will be discussing 2 or 3 in little bit detail. And if you see the efficacy analysis of drug used for painful diabetic neuropathy, you can see the numbers here. Okay. So SSRI, SNRI, tramadol, gabapentin, majority of the benefits you can see from SNRI and anti-epileptic drug gabapentin and pregabalin. So anti-epileptic drugs, mainly gabapentin and pregabalin, what is their proposed mode of action? They are approved by different guidelines, usually as a first line therapy. India also, they are being used very commonly. Availability in India is very good. Also, I would say the cost of initial treatment is also less for pregabalin as compared to other treatment. So usually they are started as a first line of therapy. They modulate the voltage-gated calcium channel. But they bind to the specific alpha to delta subunit of the presynaptic neurons. So gabapentin and pregabalin, they are available. Gabapentin was approved first line therapy for post-herpetic neuralgia. It causes significant reduction in pain. Okay, for herpes, post-herpetic neuralgia also, and for diabetic neuropathy also. The advantages of gabapentin, being an anti-convulsion or anti-epileptic drug, it doesn't require blood monitoring of their levels. This advantage we know. Side effects are very, very common for all of these drugs. Drowsiness and somnolence and generalized fatigue is very commonly reported with gabapentin, and due to low potency, the dose requirement for gabapentin is very high, and maximum dose can be up to 3,600 milligrams also. Pregabalin also approved as a first-line therapy for both herpes and diabetic peripheral neuropathy. There is usually the safety profile is good, no drug-to-drug interaction is there. The difference between pregabalin and gabapentin, the relief starts little bit early compared to gabapentin. The disadvantage is significant dizziness and sleepiness. The patient will feel increase in the sleep and dizziness coming morning also. So patients, actually workforce or the actual competency will be little bit less. Okay. So more pregabalin has lot of evidence is also around 140 clinical studies, and 20 studies are there for exclusively for diabetic peripheral neuropathy. The recommendation dose and majority of guidelines, they vary. 50 milligram TID and maximum dose you can give up to 600 milligram per day. Okay, another problem we face in India is we use very less dose of pregabalin. If you see or physician's prescription, and you see a neurologist prescription, you see the difference in doses. Neurologists, they use the recommended doses, but physicians and diabetologists, they don't use the prescribed doses. So always and always remember, the dose is more. Don't just write the 75 milligram that is commonly available once a day or half tablet of that. or you need to gradually increase the dose of pregabalin. Definitely you can start with half the dose or 1/4 of the dose and gradually you need to increase it. But you need to remember that you need to increase the dose. So these are all the doses that are recommended in the multiple guidelines. What is important thing? Even tricyclic antidepressants are also there. Again, amitriptyline and nortriptyline widely used in India. Okay, SSRIs like paroxetine and citalopram, they can also be there. SNRI, duloxetine is very important thing. Remember, selective serotonin receptor inhibitors, they are not usually FDA approved for neuropathy, but SNRI, duloxetine, you can use up to 60 milligram. You can start with 20 milligram once a day to 60 milligram once a day. Pregabalin and gabapentin, we have said. In severe cases, you can use carbamazepine or topiramate also. They are anti-convulsion drug, but you can use them with caution. Opioids are also sometimes used when the pain is very high, and you can use tramadol also. Remember the side effects of nausea and constipation. There are different side effect profiles, and habit forming or addiction is one of the things that you need to remember when you are prescribing the patient with tramadol. Okay, topical treatment with capsaicin and lidocaine. Capsaicin is again a very effective drug. Okay, whenever your patient is not getting satisfactory pain relief with 1 or 2 or 3 drugs, definitely try topical agent. Capsaicin is there. Lidocaine can also be used sometimes. Injectable botulinum toxin has few of the evidences, but we usually don't use here because of a lot of cost factor here, and even evidence is very less, and even the cost is very there. So we usually don't use much. In the last 2 or 3 things, what I'd like to highlight, the ADA guidelines, American Diabetes Association guidelines, their positional statement, it also says the same thing, but what are the recommendations does for the diabetologists or physicians to use? So ADA says you can use pregabalin, gabapentin. Remember, the dose required is high. Okay, so start with low dose. Definitely your patient will have increased somnolence and dizziness. So start with low dose, and you need to increase the dose because your patient might not be effectively controlled on a single dose of 75 milligram. Even gabapentin, you can use up to 3,600 milligram. The important thing you need to remember are the serious side effects. They can cause, almost all of them can cause hepatotoxicity. So always remember, whenever patients have signs of any raised liver enzymes or jaundice, you need to remember your patients you have given these anticonvulsants or antidepressants. Okay, all these are, they can cause suicidal thoughts and behavior. It's another thing for pregabalin, gabapentin, they can cause occurrence of new onset of seizure after rapid discontinuation. So anywhere, if you are giving a patient high doses, as you have escalated the dose gradually, you need to increase the dose even gradually to prevent these serious side effects, seizures after rapid discontinuation. Okay. Another thing is we can use TCA. They are definitely available. They have very high number of side effects. Okay. Opioids also you can use. Another important thing I would like to emphasize here, what patient needs to know. Whenever your patient has a peripheral neuropathy, you need to explain them that neuropathy continues forever. Okay? Once your nerves are damaged, there is no turning back here. Only controlling your diabetes will help prevent it getting worse. Damage will be halted if you control your diabetes, but once the damage it does, usually it continues forever, and usually it is not healed. So only symptomatic treatment is must. And what you need to know is you need to prevent your limb loss. You need to prevent amputation. So this is the basic thing all patients needs to know. Okay. And the scale of progress, Dr. Hamil has already said, while we are speaking on this topic, at least more than 2 diabetic patients in somewhere in the world have lost their limb. Okay. And the patient should know about the education. They should look for injuries on the skin and of feet daily. So daily self-examination of foot is very important. You should see us if you have any redness, bumps or blisters or sores on the skin, immediately report to your doctor. If you are having corns or calluses, don't remove yourself, visit your doctor. You should trim your toenails properly, and if you are unable to see properly or you have retinopathy or other disturbances of vision, take help from your family members. Wear good fitting and comfortable shoes, and these are the basic things what we need to maintain also. control diabetes, stop smoking, maintain your blood pressure also, exercise regularly with proper footwear, limit alcohol consumption, eat healthy diet with fruits and vegetables. In summary, I would like to say it is a multifactorial problem. The most common complication of greatest source of morbidity and mortality in diabetes patient. Despite advances in understanding the metabolic causes of neuropathy, treatments have been limited by serious side effects and lack of efficacy. As I said, it is very unfortunate for our part. It is also important not to ignore the multifactorial risk interventions such as weight reduction, smoking cessation, with controlling blood pressures and lipid control. So in the last, I would like to thank everyone, but I would like to initiate a question for Dr. Ravi sir also, that what are the impact of therapeutic carbohydrate restriction on neuropathy? Do we have any studies? I'm not sure for it, but I would like to hear from you in the question answer session coming on.
Okay.
Thank you very much.
Thank you. Thank you very much. Dr. Suri, the next presenter, if you want to talk about.
No, thank you so much, Dr. Jimit. It was a nice presentation. And I think we are coming to the end of the webinar. So we'll take the question answers. We have
So, are you guys able to hear Amar? We were not able to hear you. You had some break there. Basically, there were a few questions regarding surgery, and I'll take that question if there is no presenter else. Amar, I will try to answer the Dr. Vagdama's question regarding therapeutic carbohydrate restriction. Is a huge thing now with multiple studies and evidence that I can send you, Dr. Vagdama, and particularly evidence also is done. There is a huge resource on Public Health Collaborative. There is almost few RCTs and multiple clinical trials. I think more than 60 of them on this. And also recently there was a company that has even invested millions of dollars and did a study with a 3-year study on therapeutic carbohydrate restriction. And the major issue, what I see is sometimes we worry about carbohydrate restriction, saying that we need carbohydrates in the blood, but most of the carbohydrates that we need is made by our liver. So the issue just comes down to how we harness that potential that we have. So go ahead. You had some question, Dr. Vagdama?
Yeah, just I want to interrupt. I wanted to know the relation between therapeutic carbohydrate restriction and neuropathy.
Oh,
because
okay.
I think insulin resistant itself is a inflammatory state and it can worsen the neuropathy. So I would like to know about this thing, not in general, but regarding peripheral neuropathy.
Regarding, I mean, like I can look up more and tell you, but what I see is the major thing for neuropathy is the vasovasorum that supplied blood to the nerves, and basically just comes down to the ratio of triglycerides to glucose. In fact, there was a study that I posted in one of our groups recently. I can repost it again after the conference. I'll post it on the IPA site too. I'll particularly post that study that is shown that triglycerides to glucose ratio is very much important in what we do. Now, what happens is the dysfunction of the atherogenic dyslipidemia happens when we have more energy floating in our blood. Say, if we have more triglycerides floating in our blood, because after we do carbohydrate intake, our triglyceride levels increase. And then there is endovascular injury because there is more energy flowing and the injury happens, and that's where vasovasorum get affected. And particularly in one of the mechanisms that I have recently reviewed on the mechanisms of trying to understand why the problem of endovascular injury happens, is I'll just quickly share one thing with you guys here. I thought, okay, just one. So if you guys are able to see this screen here, this is called glucotoxicity. And with injury, normally the glucose coats the proteins, and they make it called as end products of glycation. Advanced end product of glycation worsen when we eat fructose or drink fructose. That is a major problem, the 7 times injury. So that is very important. So endovascular injury happens, and that really increases our risks of vasovasorum causing the effect, and that in turn affecting our nerves. So hopefully that helps.
Good. Dr. Ravi, it was a nice illustration. I have a question from Dr. Rama from Punjab. He's asking for, I think this is for Dr. Ashutosh Shah. How important is surgical offloading in healing diabetic foot ulcer? So Dr. Rama from Punjab for Dr. Ashutosh.
Hello. Yeah. Am I audible?
Yes, yes. So the question is, how important is surgical offloading in healing of diabetic foot ulcer? I think you have already spoken in your slides, but this is a question. This is a question.
Just for repetition, as we all are treating till now, the treatment of diabetic ulcer is offloading, external offloading. But the compliance of the patient with external offloading is initially very good, but later on they don't wear all the time. So when they don't wear all the time, the ulcers recur. And if we change the biomechanics of the foot from inside, so that the ulcer part will not bear the pressure due to that changed biomechanics, then they need not to wear the footwear for all the time, and they can have some normal life. So surgical offloading will help them to heal that ulcer within no time, like Dr. Suri said, 21 days. Hello?
Yes, yes.
Yeah, within 21 days, it will heal without any major intervention, and that will remain healed for a long time. So this is to prevent recurrence. Ulcer can heal with external offloading, and even contact cast also can heal the ulcer. But this is to prevent the ulcer, to prevent the recurrence of the ulcer.
Yeah. So for prevention, I think surgical offloading is the best thing what we can practice in our patients.
Yes, sir.
There's another very good question which has come on the screen. On the plantar surface of the foot, is split skin graft better or flap surgery? This is by Dr. Ahmed from Calcutta. I think this is also should be a very good take-home message that how to decide between split skin graft or a flap.
So split thin graft is also good on the sole of the foot if it is in the non-weight bearing part. If it is in the weight bearing part, then also if the patient is ready to wear offloading footwear, then split thickness skin graft is good on the weight bearing part also, but it has to be padded with some soft tissue inside. So if you, in sole, there are 4 layers of muscle before the metatarsal comes. So even if 1 or 2 layer of muscles are there, and if you put split thickness skin graft over there, it is okay with so many patients. Flaps are needed whenever the bone is exposed. If the soft tissue is there, or the good amount of soft tissue is there, split thickness skin graft even on the plantar aspect is good.
Yes, that's what we also practice. A lot of patients, where a few patients we have used like dermal matrix now, like Integra or Dermacell, where something the tendons are exposed or the collagen tissue is not fully developed. So that also gives a good dermal matrix for the split skin graft to occur. There's another question, sir, for Dr. Shah again. I think there are a lot of questions for you, sir. When you do surgery, do you plan offloading before or after the surgery? This is from Dr. Ekta from Raipur. So the question is, when you do surgery, do you plan offloading before the surgery or after the surgery?
Yeah, when we are doing the surgery, that part is automatically offloaded as the patient walks on walker, or we have given contact cast or something. But if the ulcer is infected, then we do debridement and we do some flaps. If the ulcer is in the second grade, then we don't debride it, we just do the internal offloading from the opposite side. Like the ulcer is on the plantar side, then we do osteotomies or tendon repairs on the dorsum side. So we need
Yes.
not to touch the ulcer when we do the surgeries for internal offloading. But if you are asking about bigger ulcers or debridements or free flaps or pedicle flaps, then we do plan the offloading, that is external offloading, after the wound heals and patient starts taking weight on that foot. And we make them understand now that this external offloading will make you walk on this footwear, but later on, if you want to prevent that ulcer again, you need to undergo the internal offloading for your convenience so that the ulcer will not recur.
Yeah.
So
Thank you.
I think once the wound heals only, thereafter we start non-weight bearing or external offload.
Yes. Thank you, Dr. Ashutosh. That was a very nice answer to this question. I have another question for, I think this is for Dr. Hemant. Is Dr. Hemant there? This is by Dr. Manisha from Gwalior. She's asking, if is TCPO2 necessary for diabetic foot clinic practice? Is TCPO2 necessary for diabetic foot clinic practice? We know that TCPO2 is very costly. A single unit would be something like 12 to 15 lakh rupees. So, Dr. Hemant, your any opinions on that?
Am I audible, sir?
Yes, sir. Yes.
Yeah. See, for each and every place running a single clinic, TCPO is not possible to have it. So
Yes.
the basic thing is, from our side, we need to examine a pulse. And if we are not able to feel a pulse, get done a Doppler. If you find a multiple stenosis, highly calcified vessels, it's better to refer it to a higher center just for the vascular workup, where everything will be available, right from measuring ABI, plethysmography, TCPO2, and then continue on the same line of the management. Is there any intervention required or not? TCPO2 cannot be maintained by each and everyone unless and until an institution is running it.
Yes. And I think the basic thing is ABI index.
Yes,
ABI
sir.
index should be part and parcel of every diabetic foot clinic. So that is one of the indicators that how you can, because if ABI index is less, then you need to refer this patient to a vascular surgeon. So for a diabetic foot clinic, ABI index by a normal Doppler or ABI, lot of machines are available now for ABI index. So that should be the basic necessary for diabetic foot clinic.
Sir, I will just like to point one point.
Yes.
Yes.
Yeah, as you mentioned ABI, I have mentioned in my first slide, always in diabetics, the vessels will be highly calcified. So we'll be getting a wrong reading of an ABI. If you get an ABI of 0.91, 1.1, it doesn't mean that there is a good blood flow.
Yes.
So if you're getting a ABI of more than 1.1, 1.2 or 1.3, it still signifies there is a calcium which is showing you a wrong ABI. So always a Doppler examination is a must. In diabetes.
In addition to that, I just wanted to add one point here, sir. Sorry, sir.
Yes.
Along with the ankle brachial index, as Dr. Hamil rightly mentioned, because of the calcified artery, there is a chance of the wrong interpretations of the ankle brachial index. But another alternative thing is non-invasive method. We can also measure the toe brachial index. Toe brachial index is actually more sensitive as compared to the ankle brachial index in diabetic foot patient. And it is also very cost-effective tool in case if they can't able to go for the Doppler studies. So another non-invasive technique we can also use is the toe brachial index. If anything more than 0.6 is considered to be an acceptable. Otherwise, usually we need to say the toe brachial index is altered. And another important point here is it directly indicates the microcirculations of the foot.
Yes. Very good answer, sir. This is a very good point of toe pressure. I have one more question coming in from the audience. What is the best screening test in neuropathy? I think Dr. Jim is with there. He can answer, or
Sir, can you
Dr.
repeat?
Maya, sir, you can also.
Yes, sir. Can you repeat the
What
question?
is the best? Yeah, I'm repeating. What is the best screening test in neuropathy in diabetic foot ulcer? Screening test. I think it should be 10 gram monofilament and biothiometer.
Yeah, can I say actually, if we look at clinically and even in the primary or the secondary level clinical setting also we can able to do, as you mentioned, the 10 gram monofilament test as well as we can also go for the biothiometer. So here if you perform these two tests, and even the recent studies have highlighted that even if there is in one particular point of the foot, if there is a change in the monofilament or the protective sensation is lost, or if the biothiometer value, vibration perception threshold is more than 25, then it is it indicates that there is an established neuropathy. And there are few articles have been published which have been compared with the nerve conduction study. If you do these two clinically, the sensitivity and the specificity of these two tests in diagnosing the neuropathy is more accurate. The standard error of estimation is less than 5%, so that we can even accept this in the clinical practice.
Yes.
Dr. Jimmy, sir. You too, sir. Dr. Jimmy, sir.
Jimmy, sir, you want to add something, sir?
No, I just had a slide in my presentation. 10 gram monofilament is a cheaper one, widely available thing. Everyone can do it in OPD, and it should be done at every, I think, for any patient, you should do it. Biothiometer, yes, definitely it is, as sir said, Dr. Arun sir said, it is also a good thing, yes.
Right.
Sir,
but as a screening, as a question has been asked about, the screening test, so I think 10 gram monofilament is one of the standard screening.
Sir, if time permits, shall I just add one more point here?
Yes.
Actually,
ahead,
sir, what we did as a part of our research, the 10 gram monofilament, even it has a good sensitivity, but it is more subjective. So the patient may say, and especially in our population, Indian population, if you're looking at the skin texture, because of the barefoot walking, there the skin texture is actually a much higher, because even if you apply 10 gram of pressure, sometimes they may not able to appreciate. So considering that, actually we have, as along with the one of the industry, we developed a force sensor, or it's also called, we have introduced the pressure sensor or the load cells, and which accurately measure the pressure. Actually, if you look at, we have a more than 1,000 people's database, even in the normal as well as we have compared in the diabetes. In Indian population, our actually the protective sensation pressure is even up to the 16 grams. Whereas in the studies, monofilament, we apply 10 gram of pressure, and then if it is absent, usually we say there is a loss of protective sensation. But this one, I think, is considering the lifestyle of our Indian population, even through this instrument, we will be able to quantify the pressure. So maybe that in the near future, in the clinical practice, I think we can use this. Basically, we can quantify the pressure and then say up to 20 gram based on our large population-based survey in the normal populations. We observed that even in Indian populations, up to 20 grams is acceptable, and chances of injury is less. But in diabetes, definitely it is more than that.
And if you are doing the screening test, the serial results has to be kept in a same paper or a same patient sheet, so that we can maintain and we can show that patient previously this was normal, now it is changing. So serial readings are also important.
Yes. So there's another question on monofilament, that can we use the monofilaments?
Reuse.
Yes.
For the same
yes, of course. Yeah.
So I think looking at the cost, the monofilament can be used for some vents. The end of the monofilament then you should not use it, because then the weight of the choice is that when we apply the monofilament on the foot of the patient, it should bend. Then only the weight of 10 grams goes on the skin. So if it is already bended, then you cannot use that filament. You should change the filament. But usually you can use it by 6 to 10 times, and then you should discard that. You should use a new filament. There's another question for Dr. Hemil. Is there any case where you do stem cell therapy along with endovascular procedure to save the patient from amputation? This is by Dr. Manish from Maharashtra. So this is a very good question. Where you are there any cases where you use stem cell therapy? We know stem cell therapy is for neoangiogenesis, where you are doing an endovascular procedure also to save the patient from a major below knee amputation. Dr. Him.
Yes, sir. So the stem cell therapy works very well. I have not personally done in Surat, but where the center from where I have learned it, that is from Bangalore, Jain Institute of Vascular Science, Dr. K.R. Suresh. We usually used to do a stem cell therapy for the patients with unreconstructible diseases. If the patient is able to undergo endovascular or bypass, then the stem cell is not needed. But if the vascularity is such that we cannot do any revascularization, then the stem cell therapy nearly works very well.
Okay. Thank you, sir. Thank you. It was a very good answer. And Dr. Ravi, do you have any more questions on the screen? Dr. Shailesh?
Yes, I do have one. The different.
Yes,
I think one question I saw Manish asked earlier. I think I don't know if
contraindication of surgical offloading.
Elaborate the role of nutrition in diabetic foot ulcer.
Yeah, I mean basically it's the same thing. I mean we can have another complete 1 hour lecture on it. You know, nutrition nutrition is a huge thing, and we need to, even as surgeons, even as medical doctors, even as anything that we do in medicine, nutrition is the root of it. I think we have to rethink everything, and not just rethinking, empowering and changing ourselves first, and then changing the doctor. So it's a 1 hour deal that we will have later. But I think one question Manish had earlier again was what are the contraindications for surgical offloading? I would say vascular disease, peripheral vascular disease, but Dr. Shah can elaborate if there is anything more than peripheral vascular disease that would be a problem for doing surgical offloading. You don't want to cut on people who have vascular disease until you correct them, and you get to have a good vascular surgeon on your team. It's all about toe flow, and but then is there anything more than vascular disease that is a contraindication apart from, say, vascular disease and infection?
Sir, we are lucky that we have a team of Dr. Shailesh and Dr. Hemil with me. So as a vascular surgeon, Hemil is doing good. Then as a plastic surgeon, I am there, and Dr. Shailesh is also working as a podiatrist with us. So we are lucky in Surat to have a whole team with us, and Dr. Jimit is also there with us for our support. So as a team, we are providing good results here. And there was one question from Pradeep Chopra, that should we exercise all exposed tendon? So I like to answer that if the tendons have paratendons on that, and if they are live, you can do split thickness graft over that. But if the tendons are dead, then you need to excise them. But before, don't allow tendon to get dead. You need to cover it with negative pressure wound therapy. So slowly they'll granulate, and then you can do split thickness skin graft over that, or take opinion of plastic surgeon and cover it up with the flap, so that the function as such, we are damaging, if we cut the tendons, we are damaging the function of the foot. So try to preserve the tendons till they are live, and try to keep it live with various hydrocolloid dressings or negative pressure wound therapy and early coverage.
Thank you. Thank you very much. And it was a good session we had today, but I want to close this session with one thought. Basically, it's a teamwork that makes everything happen. And we need to understand that in healthcare, we deliver what we do excellently. But this, my friends, is a huge, huge thing. And toe and flow, every person in this whole thing is very important. And obviously, a podiatrist, vascular surgeon, infectious disease. I know we don't have many infectious disease doctors there, but diabetologist, plastic surgeon, and all these surgeons all these people are very important. And what I urge all of you guys is find your team and bring them to IPA. And we have resources in all of IPA, and we can have them go at different places. IPA is coordinating different things with Dr. Suri's leadership. And we're going to try to say, if there is a problem with anything, we can have all the people, all the speakers today. We will be guide. We will help you do it. And the team approach is what we are going to do. And using people, process, and technology will help the healthcare change in India and across the world. And thank you very much. With this, any closing remarks, Dr. Suri, and we can say bye. And please don't forget to put your name, email address, and location so that we can record that you were attending.
Yeah, thank you so much, Ravi. I thanks to all the speakers for a very nice and elaborate presentations and giving a very good take-home message to all the audience over there. I thanks to all the audience who have participated and taken our time during this period of COVID. Now we are starting to practice and we are slowly getting busy. Just a point to mention, as Dr. Ravi has said, that Indian Podiatry Association is working very hard. Mainly the main goal is to spread education among the doctors dealing into diabetic foot care or lower limb disease processes. With this, we are recently going to launch Indian Podiatric Physiotherapy Association. If you can see on the screen, with Ravi over there, Dr. Rajneesh Saxena, Dr. Arun Maya sir, and Shailesh Chotala, Dr. Palvi Singh from Mumbai, Dr. Dhara from Surat, Dr. Vandana from Delhi. So all the team is there. This is a separate group or new group coming up where podiatry physiotherapy, because all of us knows that offloading the technique or offloading the foot is the most important thing in dealing with diabetic foot ulcer. Whether the patient is coming to a surgeon's clinic or it is coming to a physician's clinic or even to a vascular surgeon or plastic surgeon's clinic, the main thing what we have to practice is, along with the surgical technique, we have to do offloading. So I think pod physiotherapy or podiatric physiotherapy group is one which will work hand in hand with all the surgeon friends and deliver good results to the patient. So we are going to have two webinars, one on 31st of May, that is Sunday, 2 days from now, where Dr. Palvi, Dr. Shailesh, Gurleen Suri, she's a podiatrist from UK, and Dr. Arun Maya sir, they will give their presentations. And then we have another presentation on 5th of June, where we will have presentations from again by Dr. Dhara, Vandana, Shailesh, and Dr. Bipin, where Ravi and Dr. Maya will be the moderators. So join us on 31st of May and 5th of June. So these are two upcoming webinars. And Indian IPPA group is coming up and we're trying to bring together all the people dealing into offloading and biomechanics of the foot under the leadership of Dr. Arun Maya sir. So I give now the last vote of thanks by Dr. Shailesh, and he's the main torch behind this webinar which we have done today. And he was talking with me, and I said, okay, we'll go ahead. And Dr. Ravi, we thank you all for this Zoom web connection and everything he has done from his portal from USA. This all we are connected through Zoom from USA. And thank you to you for taking out time, and thanks to all the delegates. Dr. Shailesh, please on the webinar.
I conclude the today's webinar that Dr. Maya sir is a very senior, as Dr. Suri sir said. Thank you very much to joining, and Dr. Asuta sir. Actually, sir doesn't know that today is the webinar, but thank you to thanks to you and your team that you made it possible today, and thanks all the participants, especially our moderators, Dr. Ravi sir, as he already woke up early in the morning, and it is made by the meeting ID and all the passwords by Dr. Ravi sir. So I thank you all the delegates, and especially who are interested in the diabetic foot care treatment and the outcome of the diabetic foot ulcers. Please contact me or any of the delegates, or any of the moderator who are presently give a good sessions today. And I thanks Dr. Hemil and Dr. Dharmesh Davra too to attend this webinar and made it successful today. Thanks you, all of you, and now we can conclude, and we will have a good webinar series in the future.